Okay, hello and welcome everyone to our webinar Wednesday for Colorectal Cancer Awareness Month. Okay, then we're going to go ahead and get started. Hopefully everyone can hear me okay. As I mentioned, March is Colorectal Cancer Awareness Month. And so our speaker for today is going to be giving us some basics about colorectal cancer, all the things that you need to know in one webinar. And we're calling this Colorectal Cancer 101. Today is March 17th, so of course, happy St. Patrick's Day to all of our friends. I'm wearing my only green shirt that I own to be festive today. Okay, so just as a reminder, please make sure that you put your microphone on mute and remain muted when you're not speaking. We are streaming this live to Facebook, so feel free to turn off your cameras if you'd like to. We're also recording this and we will send along the recording following today's webinar. If you have any questions at any point, please type them into the Zoom chat box. And for those of us who are joining us on Facebook Live, you can use the comments section to submit any questions that you have for our speaker today. This webinar is being brought to you by the University of Chicago Comprehensive Cancer Center, Office of Community Engagement and Cancer Health Equity. We are the community engagement arm of the Cancer Research Center at the University of Chicago. And we try to bridge the gap between our community stakeholders, our community partners, and the cancer researchers and all the great work that we're doing. And part of that is this Webinar Wednesday series today that we bring to our community partners as well as our University of Chicago employees. Our speaker today is Dr. Matthew Odenwald. He's a physician scientist here at the University of Chicago. And I don't have any other introductions. I'm going to allow Dr. Odenwald to introduce himself, and I will stop sharing my screen so that he can share his. So Dr. Odenwald, there you go. Perfect. You're on mute, Dr. Odenwald.
All right, there we go. Can everybody hear me now?
Yep.
All right. Well, thank you again for the introduction. My name is Matt Odenwald. I'm one of the second-year GI fellows here at the University of Chicago. And today we're going to be talking about the basics of colon and rectal cancer. And as we've already heard, this is Colorectal Cancer Awareness Month. So if you see anyone walking around the hospital with blue ribbons such as these or the one that I'm wearing, they're showing support for all the awareness efforts that are taking place for Colorectal Cancer Awareness Month. So a brief overview of today's talk is that we'll start by talking about both the epidemiology and risk factors for colon cancer. So who is at risk for colon cancer? Then we'll talk about symptoms of various stages of colon cancer. And we'll spend the most of our time talking about the ways that we can screen for colon cancer and how we diagnose it. And then at the end, we'll talk just a little bit about treatments for colon cancer, although that's a little bit more advanced and probably for another talk for more. So colon cancer is incredibly common and throughout the world, but it does have geographic variation. So in this graph here, we have a heat map where really dark blue countries are countries that have very high rates of colon cancer, and light blue or gray countries are countries that have very low rates of colon cancer. And you can see that while it's across the world, those with the highest incidence of colon cancer are countries in all of Europe and developed countries such as the United States. So since we're in the United States, we'll focus mostly here, but colon cancer is quite common here. And of both males and females, colon cancer is the fourth most common cancer diagnosed. This is behind female breast cancer, prostate cancer, lung cancer, and then colon and rectal cancer is the fourth most common cancer that's diagnosed. It's estimated that in this year alone, nearly 150,000 new cases of colon cancer will be diagnosed here in the United States. And similarly, colon cancer is responsible for the fourth most deaths related to cancer. And that's again behind lung, breast, prostate, and then colon and rectal cancer is next. And it's estimated that this year about 53,000 deaths will occur in the United States alone just from colon and rectal cancer. So the number one risk factor for developing colon cancer is birthdays. So in this graph here, we have the rate of colon cancer per 100,000 people. So the higher a bar is, the higher the rate of colon cancer in that age group is. And on this axis here, there's age going from younger, from 20 years old up to 85 plus years old. And as you can see at each different age group, there's a much higher incidence of colon cancer, with the highest incidence being in those over 85 years old. But these graphs are a little bit complicated, but I'll walk you through it. But the incidence of colon cancer is rising in young people right now. So these graphs are similar to the last one, incidences over time. And we can see that each one of these graphs is going up and to the right, suggesting that, or indicating that there's a rise in colon cancer in young patients. And this is in stark contrast to older patients who regularly get screened for colon cancer from age 50 to 85 plus. You can see that all of these graphs go down and to the right. So the incidence of colon cancer is falling in that age group. Now, these graphs aren't directly comparable because the axes are different on each of these. So the rate of colon cancer is still much higher in these older patients, but there's a striking trend towards rising rates in younger patients. So with that being said, we should really go over the basics of what is colon cancer. In these pictures here, we have various stages of cancer development. So on the left, we see a picture from a colonoscopy, and that's a normal colon. So this is a perfectly healthy colon mucosa. In the next picture to the right, there's a small polyp. It's so small that you may even miss it if you were looking for it. So I've put arrows around it. There's this really small area that's not quite the same as the surrounding mucosa. Then there's a large polyp in the next picture, and that's a bit bigger, and then a full cancer on the far right side. So in this full cancer, you can see that there's a very narrow lumen or very narrow opening, and that is causing some symptoms. So what causes these cancers? So from normal tissue can give rise to polyps after some genetic mutations can occur for various reasons. And over time, these polyps will grow and they can accumulate more genetic mutations and develop larger polyps and eventually transform into cancers. So our goal when we do colon cancer screening is to catch and remove polyps in these early stages before they grow into larger polyps or even become cancers. And if cancer does unfortunately occur, our goal is to catch the cancer very early so that they can be taken out and cured. So one of the big hangups about screening for colon cancer is that polyps and even early cancers often have absolutely no symptoms whatsoever. So in a small polyp and even large polyps, there's often no symptoms at all. And then cancers themselves, when they do develop, the symptoms can often be non-specific. And what that means is that they can be symptoms that people that are perfectly healthy have. So patients can feel constipated, they can have narrower stools or have obstructive symptoms, which is inability to pass gas or inability to pass stool. They feel bloated or have abdominal pain, weight loss, and then more alarmingly, patients can develop rectal bleeding, anemia, and fatigue from that. So many of these symptoms can be due to many different disorders and can even occur in healthy people. So even when symptoms do occur, they're not specific to say this is colon cancer. So really that leaves us to screen patients. So the big question is who should be screened for colon cancer and how should we be screened? So we'll spend a lot of time here talking about each of these. So as I mentioned earlier, the number one risk factor for colon cancer is just getting older. So there's many different guidelines for who should be screened for colon cancer in the average risk population. And the current guidelines for United States Preventative Services Task Force recommends starting at age 50 for colon cancer screening. However, this is in contrast to the American Cancer Society guidelines, which recognize that there's now a rising incidence of colon cancer in younger patients, and have recommended bumping that down to 45 years old. Importantly, for most of you or for everyone in the audience, is that insurance companies will now pay for colon cancer screening at age 45. That's an important thing to know, and I was preventing quite a few patients from getting it early when they wanted to get it earlier. Then the guidelines then recommend screening from up until age 75. So this is again for the average risk patient. So some patients are not at average risk, they're at higher risk for colon cancer, and they should be screened before the age of 45. These patients that are increased risk, the number one risk factor that we often see is family history of colon cancer. So if there's a family history of colon cancer before the age of 60, or any family members with advanced polyps. So these are often larger polyps that have specific morphologies when we look at them under the microscope. Those patients are at increased risk. And they should be screened starting at age 40 or 10 years before the diagnosis of each of these conditions in their first degree relatives. So oftentimes even younger than 40. Importantly though, family history is really for a first degree relative. That's where a lot of the risk comes from. And a first degree relative is anyone you're directly related to. So that would be parents, full siblings, and children. Additional people who should be screened for colon cancer at an earlier age include those with known genetic conditions that predispose them to cancer. Common ones that you may have heard about are Lynch syndrome, and those with inflammatory bowel disease, which that would be a topic for another discussion. And after age 75, the guidelines recommend that this should be individualized. So we don't recommend it to screen everybody after age 75 for colon cancer for many reasons, but partly because there's an increased risk of other causes of death after age 75. And the procedures that would be undertaken to do colon cancer screening have a higher risk in this population. So this should really be a discussion with a more nuanced discussion between a physician and the patients themselves. So once you've decided that you are a good candidate for colon cancer screening, or you and your doctor have decided you're a good candidate for colon cancer screening, how should you be screened for colon cancer? There's lots of different options out there, and we'll go over some of the main ones in just a second. So colon cancer screening can really take on one of two main approaches. The first approach, and oftentimes the most palatable to patients, is a stool-based test. And this test, these are a few names are down here, and I'll go into each one a little bit more detail in a second. And the other tests are directly visualizing the colon, and that's the most common of this is a colonoscopy. So for stool-based tests, they offer a really great option for many patients to get screened for colon cancer. And the oldest one of these is a fecal occult blood test. And what that looks for is microscopic amounts of blood in the stool. And if it's negative, this needs to be done every single year. The advantages of this is that it's not invasive. You're just giving a sample of your stool. There's no prep needed. It's pretty cheap and widely available, and very sensitive for detecting colon cancer. But there can be false positives. So anything that causes bleeding in the colon, including hemorrhoids, can cause false positives on these tests. And diet and medications can interfere with this test and cause it to be falsely positive. The fecal occult blood test has really largely been replaced by fecal immunochemical test, or FIT testing. And this looks for intact hemoglobin in the stool. Hemoglobin is a component of the red blood cells. Again, just like fecal occult blood tests, this needs to be done every year if it's negative. This is more sensitive than FOBT, meaning that if there is colon cancer, it will pick it up more often. And many studies have been done and shown that it's between 80 and 91% sensitive for cancer. This can often be done in a single stool sample. And just like FOBT, there can be false positives, but for colon cancer itself, it's about 94% specific. So if there's a positive result, it really needs to be taken seriously. The one caveat, though, is that, as we mentioned earlier, we really want to use these tests to find early polyps so that we can take them out early and prevent them from becoming colon cancer. And these aren't quite as good at detecting advanced adenomas or even or much smaller polyps before they grow and become colon cancer. So that's one caveat to this test. Really, the new kid on the block for this, for non-invasive stool-based tests, is something called FIT DNA. And the brand name for this that you've probably seen ads for on TV is Cologuard. What this tests is the same thing as FIT testing, so hemoglobin in the stool, but it also combines that with a tumor DNA test. And so if this is negative, this should be done every 3 years according to the guidelines as they stand right now. This is more sensitive than FIT testing, so it's about 92% sensitive for colorectal cancer, but it is less specific, so there's more false positives. It's a bit more costly than either one of the other tests, and it's a newer test. So we as gastroenterologists and primary care doctors are still learning exactly how to interpret this test and how to follow up negative tests, when to follow it up, and how to follow up positive tests even. So there's still quite a bit to be learned about. So next we'll talk about directly visualizing the colon for colon cancer screening. And many patients feel like this is what we're doing with me as the gastroenterologist on the left and the patient on the right. And sometimes it's not too far off. So we'll talk a little bit about these tests in a second. So some of the tests that we do is, this one's not used very often, but a CT colonography. And this is a CAT scan that looks for large polyps and early cancers. If this is negative, it needs to be done every 5 years. And the advantages are that it's not invasive. There's no anesthesia required. And it's really good at detecting large polyps and nearly 90 to 100% sensitive for detecting colon cancer. But in order to get a good look at the colon, this requires a bowel prep. There is radiation exposure. There can be incidental findings, so findings in other organs that require follow-up and may lead to many more invasive tests. And there's a poor ability to image flat lesions or smaller lesions. So we often don't get the best look at the colon to take out those smaller lesions. So flexible sigmoidoscopy is the next test we'll talk about. And this is similar to a colonoscopy, but it only goes into the very end or the left half of the colon. And if this is negative, we still recommend doing it every 5 years. And the advantage is that this takes a direct look at the left colon, and you can remove polyps and the precursor lesions if while you're in there with the scope. This requires a bowel prep. There's procedural risks that we'll talk about in a little bit. And the other main disadvantage is that it misses the entire right half of the colon. So many have likened this to doing, it's not the perfect analogy, but many have likened this to doing a mammogram just on one breast. Because of this, flexible sigmoidoscopy has really largely been replaced by a full colonoscopy. And this is a camera that goes into the entire colon. And if it's negative and you're an average risk patient, this should be done every 10 years. This takes a direct look at the colon and can remove polyps while you're in there. But it does require a bowel prep and has procedural risks as well. So importantly, many patients may want to do a non-invasive test, and that's very understandable to want to not go through a fairly major invasive procedure just to screen for a asymptomatic disease. But if each of these tests is negative, this fecal occult blood test, FIT DNA, or the CAT scan, you would need to repeat those in 1, 3, or 5 years, depending on which test you're choosing to do. However, if any of these is positive, it really needs to be followed up with a full colonoscopy to look for why it was positive. Why was there blood in the stool causing the FOBT or FIT or FIT DNA test to be positive? And what was causing those the imaging abnormalities on the CAT scan? They really need to be directly looked at. Because of this, colonoscopy is often considered the gold standard for screening for colon cancer. And so the rest of the talk for screening will really be talking about and focused on colonoscopies. So colonoscopy is a visual examination of the colon, and it takes a long flexible tube, and that tube has a light and a camera on the end of it, and it goes into the rectum, and it then snakes around the entire colon into this area called the cecum, and this is on the right colon. And the advantage is that it directly looks at the colon lining, and it can detect and remove polyps, which are precancerous lesions before they turn into cancer. With colonoscopy, many studies have been done, and they've shown that the incidence of colon cancer has been reduced dramatically with colonoscopy, as is the death rate from colon cancer. So the most recent studies in the United States have shown that patients who undergo colonoscopy for colon cancer screening have about a 71% reduction in even developing colorectal cancer. And this is similar to the death rate from colon cancer. The most recent studies in the United States showed about a 70% reduction in mortality from colon cancer with getting a colonoscopy. But colonoscopies aren't without risks. It requires a bowel prep, and so that comes with the risk of becoming dehydrated, having electrolyte imbalances, or even kidney injury from the bowel prep. Their patients could have adverse reactions to sedation or the anesthesia used during the procedure. And the procedure itself can cause bleeding at a very low rate of 8 per about 10,000 colonoscopies, but that is a higher rate if we're taking out polyps. And the most feared complication is a perforation, and that is a small tear in the lining of the colon that often requires surgery to repair. And again, that's higher if we're actually doing something like taking out a polyp. And one of the other feared complications is missing a lesion. So we're taking a look, but sometimes it's very difficult to see behind every single fold. And so it's possible that we do miss a lesion, and a colon cancer develops between a negative colonoscopy and the next colonoscopy. Luckily, this is quite rare and happens about 1 in every 3,000 colonoscopies. So while these complications and feared missing of colon cancer can be quite devastating, they are quite rare, and overall, the benefits of colonoscopy outweigh the risks for the majority of patients. So many questions will probably be centered around, how do I prepare for my colonoscopy? And the Comprehensive Cancer Center has really put together this outstanding website on all the details you'll need to know for preparing for a colonoscopy, including the bowel preps and all of the different bowel preps that you can take. So if you Google University of Chicago colonoscopy prep instructions, it will take you to this page, and there's many links that we don't have time to go over today, but I would encourage you, especially a couple of weeks before, if you're having a colonoscopy, a couple of weeks before, to take a look at this site. But one of the main things that everybody knows about who's been scheduled for a colonoscopy is that a clean colon is required for a thorough exam of the colon. So shown here are a couple of pictures from left to right. This is a perfectly clean colon that we can get a really great look at and screen for even those small polyp lesions. And on the far right is a colon where I can't imagine that this patient took any of the prep. And this is a colon just full of stool. And as you can see here, we can't see any of the lining of the colon in this picture on the far right. And so we can't do a good exam. And that's really a colonoscopy that needs to be repeated as soon as possible, because we would simply abort this procedure and not proceed, because we wouldn't get a good exam, and it would put you at increased risk for procedural complications because we can't see where we're going. So cleaning the colon requires a combination of diet and laxatives. So diet changes leading up to your exam include a low residue diet about 2 to 3 days before the exam, and that includes low fat diet, low fiber diet. And then on the day before the exam, you should have a clear liquid diet. A clear liquid diet is anything that you can see through. So coffee without milk, broth, jello, things like that are all included in a clear liquid diet. And then nothing to eat on the day of the exam, because we want to have the cleanest colon possible, but also minimize risks of anesthesia. And then everyone who's had a colonoscopy remembers the giant jug of prep material that's needed to evacuate stool from the colon. And the most common is a generic medication called Go Lightly. And this is a 4-liter jug of fluid that needs to be taken half the night before and half on the morning of the exam. But again, there are various different laxatives that can be used to evacuate stool from the colon. And all of those instructions are really detailed on that Comprehensive Cancer Center website that I mentioned just a couple of slides ago. A couple of other things that are really important for a lot of patients is that is talking with your doctor about medications prior to having a colonoscopy. So blood thinners are one major class of medication, and the other one is diabetes medications that need to be modified prior to having a colonoscopy. So for blood thinners, you have to check with your doctor to make sure that it's okay and safe to hold the blood thinners prior to a colonoscopy. And if it's not, we should really push off the colonoscopy until it is, because polyp removal cannot be done safely while taking blood thinners. There's just too high of a risk of serious bleeding if a polyp is removed while taking a blood thinner. And diabetes medications should generally be decreased or held entirely prior to the colonoscopy, and that's because you're eating less and having less sugar in your diet at that point. So for oral medications, they're typically held 1 to 2 days prior to the procedure. And insulin, the long-acting insulin, is typically 1/2 the dose of insulin, and then holding the short-acting insulin on the morning of. You'll need a ride home from this procedure. You can't drive after receiving anesthesia or sedation, and you'll need to take that day off of work because you can't make any important decisions for the next 24 hours after having anesthesia. So the timing of your next colonoscopy really depends on what's found during your first one. So a normal colonoscopy, an average risk patient, so that's a patient with no family history of colon cancer and no predisposing conditions to colon cancer, we would say we'll see you back in 10 years. But if polyps are found and removed, it really depends on the type of polyp, number of polyp, and size of polyps that are found during the exam. And we may say come back between 1 and 10 years, depending on what we find during that exam. But that will be individualized with each colonoscopy. And so lastly, I'll talk just very briefly about colon cancer treatment in very broad strokes terms. And this really depends on what stage of colon cancer is caught. So in stage 0 colon cancer, there's abnormal cells that are just in the lining of the colon, and that's often treated with a polypectomy that can be cured with a colonoscopy itself. So we often take those out while we're in doing the colonoscopy. Stage 1 is colon cancer that's invaded just a little bit deeper into the lining called the submucosa, and that sometimes requires surgery with a resection of that segment and then plugging the bowel back together, called an anastomosis. And some institutions such as ours also offer advanced endoscopic techniques. So this is with the scope like a colonoscopy, they can dissect under here and leave the colon entirely intact. But that needs to be, whether or not that's a right treatment for stage 1 cancer, needs to be a close discussion between the advanced endoscopist, the surgeon, and the oncologist. For more advanced colon cancer, such as stage 2 and stage 3 colon cancer, these are colon cancers that have invaded farther into the muscular layer and even have local metastases either into the lymph nodes or into nearby tissue. Those always require surgery at the current moment. And stage 3 cancer that's gone to the lymph nodes requires chemotherapy afterwards. And stage 4 cancer, which is metastatic, often requires chemotherapy and may require procedures for palliative purposes. So take-home points is that colon cancer is very common and unfortunately becoming more common in young people. The precursor lesions and early colon cancers are typically asymptomatic, meaning that they can be developing and we have no idea. The ideal colon cancer screening detects precursor lesions and early colon cancers, and this can take on a couple of different forms, including stool-based tests, such as the FIT test, and tests that visualize the colon, such as a colonoscopy. And all of those are acceptable modes of colon cancer screening. You just need to know the drawbacks and benefits of each one of the tests before undergoing that test. For the time being, colonoscopy is the gold standard screening test, and it's required for any positive non-invasive test. And if diagnosed with colon cancer, The treatment really depends on the stage of colon cancer and typically involves a multidisciplinary team of oncologists and surgeons to treat you the best you can. So with that, I'll say thank you and see if there are any questions from the audience.
Okay, huge thank you to Dr. Odenwald. I love the picture there. So we do have we got a couple questions here in the chat. A couple came directly to me, and a couple are in. Actually, they look like they're all directly to me. Okay, so first question up, is stage 4 colon cancer curable?
All right. So it really depends on how widely metastatic the colon cancer is at that point. Sometimes if there's a single metastases of a small size to the liver, that can be resected, and the primary colon cancer can be resected as well. So it really, but if there's much more widespread metastases, that would really often require distant chemotherapy to cure or to treat, and it's often not curable, but patients can live for a while depending on how widespread the colon cancer is.
Okay. I have a question here about just some disparities in colon cancer. So we know that it affects, people who are more advanced in age. And then just, is it more prevalent in men versus women? Do we see any racial or ethnic disparities?
Yeah, so I'm not quite as familiar with that, but I know that we do see some more. The disparities we do see in African American populations, we often see actually more right-sided colon cancers. So those colon cancers that are on the right side of the colon that would be missed by things like a flexible sigmoidoscopy. And those colon cancers on the right side often take on different types of, they're often different types of polyps and actually more aggressive cancers. So there is a disparity in that respect. But both of the cancer types, colon cancer is the third most common cancer in both men and women, and it's the fourth most common cancer overall. So
Okay.
it's very common in both genders, and really for the time being, the colon cancer screening guidelines don't take into account any differences between men and women or differences based on race.
Okay. And so, you talked about the different screenings, and we hear this a lot in the work that we do, that colonoscopy is the gold standard. And so would you say then, like, barring any sort of barrier to doing a colonoscopy, if people have the option, should they opt for that if they have the choice?
No, it's really that's really a patient and physician decision. So that the non-invasive tests such as the FIT and the FIT DNA test are quite sensitive, as we mentioned, and they're done much more frequently. So if something is to develop, they are likely to catch it. But many patients will say, I don't want to go through another test. If I do, I just want to do one and done. And so if you're someone who wants to do just one test, I would recommend doing, and you have the option to do a colonoscopy and you're not at prohibitive risk from a procedural standpoint, I would say go for the colonoscopy. But if you're okay doing multiple tests, then I think doing one of the non-invasive tests is really just as good, but you have to be okay with doing multiple tests if it's positive and doing a colonoscopy if it's positive as well.
Right. And really staying on top of that from year to year.
Yeah, and so that can be very difficult. The way that we do colon cancer screening in the United States is really opportunistic, meaning that it's when you go to your primary care doctor or you show up at a specialist's office, sometimes they'll say, have you had your colon cancer screening? And then ask about it that way. But it's not really a systematic screening where we're reaching out to many people at one time. And so since we are doing it opportunistically, it's more than often than not, a one and done approach is the easiest and quickest way to do things.
Sure. So we have a question here about some of the early symptoms, and we have a couple questions about symptoms. So, and I don't know if you want to go back to that slide or just review. So someone asked, what are some of the early symptoms of colon cancer, if any?
Yeah, so let me go back to the slide. So these early lesions, I'm going to try to get this out of my way. So these early lesions, such as polyps and these large polyps, oftentimes don't don't result in any new symptoms whatsoever. So these can go largely unknown by patients, and that's why we really recommend screening everybody regardless of any symptoms. And then colon cancer itself, if it's an early cancer, that can often be no symptoms either. And it's usually the later stage cancers. This cancer here is actually a pretty advanced cancer that's causing almost obstructive symptoms, but it's usually the later stages that start um, developing symptoms, and these include these pretty non-specific symptoms too. So constipation is one potential symptom, but people can be constipated for many reasons. People can have bloating for many reasons or abdominal pain for many reasons, and so there's not really one or definitive set of symptoms for colon cancer itself. And then it looks like in the chat, there's also a question about symptoms between right and left-sided colon cancers. And that's a very good question. So depending on where the cancer is, it may result in potentially different symptoms, but it's more the how advanced the cancer is to developing which symptoms you develop. But you can imagine that a left-sided cancer that's closer to the rectum and maybe bigger would result in more bright red blood from the in the toilet or things like that. But all of them can develop obstructive symptoms and really all of the symptoms listed here.
Um, and then I have a question here asking, are there different screening guidelines for people who have Lynch syndrome?
Yes, so there are different screening guidelines for patients who have Lynch syndrome, and that is often to get I'm not entirely sure about the exact timing of it, but it's usually in their really early on, so in their 20s, we start screening, and we end up screening almost every year with a colonoscopy. So it's much more often. Patients with Lynch syndrome are also more prone to developing other types of cancer, and so it's something that needs to be addressed. We do have Dr. Kupfer here at the University of Chicago, who is an expert in this area, and so if you or a family member has Lynch syndrome, or you know anyone that does, I would certainly recommend seeing her. She's really outstanding, and is make sure that you're on top of all of the recommended screening for colon cancer, upper endoscopy, and then other cancer screening. So it's a predisposition to lots of different types of cancer that I would recommend seeing a specialist that also has a genetic counselor component to it too, so that you can make sure that family members are also being diagnosed and screened properly too.
That's a really great point. We did a webinar a couple months ago with Dr. Kupfer and one of the genetic counselors, and they kind of talked a little bit about how they work in tandem for these genetic risk factors for Lynch syndrome and for other cancers, but specifically Lynch syndrome for Dr. Kupfer and her work. And so I do want to plug again the University of Chicago in that manner, because I know that our oncologists work really closely with our genetic counselors to make sure that we're catching these things. So if you do have a family history of colon cancer, if you know of a family history of Lynch syndrome, make sure that you're talking to your physician and getting the testing that you need to make sure that you're making the most informed screening choices for your personal situation.
Yeah, and I think the other thing is that all of those non-invasive tests that we talked about really should not be done in patients with really high risk of having colon cancer or developing polyps. In those patients, we recommend direct visualization with a full colonoscopy, because there is such a high risk of developing polyps, and the polyps that develop tend to advance to cancer a little bit more frequently.
Okay. And then there is a question just about like general prevention. What are sort of the some lifestyle factors that may, besides genetics and age and all that, some other lifestyle factors, and what can people do to take their health into their own hands and their prevention into their own hands?
Yeah, one of the main things that we can do is actually diet. So there have been many studies about diet and colon cancer, and they seem to show the same thing that a lot of the studies for other health conditions show. So things that are healthy and have decreased incidence of colon cancer are patients that are eating a lot of fresh fruits, fresh vegetables, things like that. And patients who have higher incidence of colon cancer tend to be eating a lot more red meat and processed meats that have potentially some carcinogens in them. So we don't recommend saying cut out all red meat, but maybe in moderation is really the way to go, and trying to replace things like that with healthier things like salads and fresh fruits, fresh vegetables. The other one that's pretty interesting is exercise can also actually reduce potential risks of colon cancer. It's kind of a short-lived benefit, but if you're actively exercising, that helps too. And then no smoking too, is decrease smoking and don't smoke. So it's a lot of the things you've probably heard over and over for many different health conditions, but they hold true for colon cancer too.
Yep, we're always happy to, every expert faculty that we have on here, we sort of ask some of these questions about the different cancers, and it's always the same. And so it's always good to remind everyone about how important it is to eat healthy. And when our smoking cessation people are on here, they really hammer that home. But every disease sort of says the same thing, that all these risk factors play into all different kinds of cancer and all different other kinds of comorbidities. So yeah, always good to hammer that point home. And thank you for that reminder. Okay, I don't see any other questions here in the chat box. So I'm just gonna ask one more time. If anyone else has any other questions for Dr. Odenwald, you can either, you can unmute yourself and just ask directly, or if you prefer the chat box, you can use that. I'm gonna double check and make sure that we don't have any other, any questions coming in from Facebook Live. Okay, no questions on Facebook Live, no other questions in the chat box. All right then. So thank you so much, Dr. Odenwald, for coming and speaking on all of this information today. We really appreciate it. So informative, and thank you for taking time out of your day to chat with us today. I'm going to stop the Facebook Live feed. So thank you to all of you who joined us on Facebook Live.